Dr. Joseph William Heflin, and I'm an internal medicine physician. I'm a clinical preceptor of medicine at UNR School of Medicine, have been published in Porphyrias, and I have also been working with the American Porphyria Foundation since its inception. I've treated many patients with various types of porphyria, and we are putting this presentation together to address the frequently asked questions that porphyria patients have to help eliminate some of the confusion regarding diagnosis and treatment.
I'm Desiree Lyon, Global Director of the American Porphyria Foundation, and Dr. Heflin, I have a few frequently asked questions. The first one is, how does a person even get porphyria?
Okay, most porphyrias are inherited. One type, Porphyria cutanea tarda, is inherited or acquired. In each type there is a deficiency of an enzyme. These enzymes are involved in heme synthesis. The type of porphyria is determined by which enzyme is deficient. These enzymes are involved in the synthesis of heme, found in large amounts in red blood cells and bone marrow.
Dr. Heflin, what diagnostic tests are available, and can you elaborate a little bit on that?
Certainly can. There are many diagnostic tests that are available. The correct test depends on the type of porphyria that your doctor suspects. The Porphyria Foundation has a doctor packet that shows your doctor what labs to order for each type of porphyria. It's very important for the doctor to order the correct test. For example, in acute porphyria, some doctors only order porphyrins. When they see elevated corporate porphyrin, they assume mistakenly that the patient has corporate porphyria. Porphyrins can be elevated for many reasons. They can't be used alone for diagnoses. Therefore, for biochemical testing or DNA testing, consult the American Porphyria Foundation. There is also free DNA testing available for the acute porphyrias. You can contact the Porphyria Foundation and they will be a source of information on the free DNA testing to give to your physician.
Dr. Heflin, can a person have more than one type of porphyria?
It's extremely rare to have any type of porphyria, but there have been some documented cases where patients had two types of porphyria.
Dr. Heflin, can you explain each type of porphyria in layman's terms?
I certainly can. Almost all cells in the body contain heme proteins. Heme proteins, such as hemoglobin, are valuable for transporting oxygen and carbon dioxide throughout the body. Other heme proteins are also important for breaking down drugs, toxins, and other harmful substances. The process of producing heme in the cells is called porphyrin synthesis. The porphyrin synthesis process requires 8 enzymes to produce heme. If there's a defect in any one of these enzymes, less heme is produced and an excess in certain types of proteins occur, which can be toxic to the nerves or skin, resulting in nerve damage, abdominal pain, or skin blistering. The group of genetic diseases associated with defects in the enzymes that produce heme is called porphyria. There are 8 different types of porphyria. AIP, acute intermittent porphyria, is a chromosomal dominant inherited gene defect in heme production. Most patients have no symptoms, but if symptoms are present, they can be very debilitating. The most common symptom is vague, crampy abdominal pain that can last over several hours, days, or weeks. Associated symptoms include vomiting and constipation. Sometimes the pain can occur in the chest, back, or extremities. Severe attacks may lead to loss of movement of an extremity. Attacks are most common in young adult women, typically occurring between puberty to menopause. Diagnosis is made by a urine test during an attack, identifying an elevated porphyrin protein called PBG, porphobilinogen. Second type of porphyria is VP, variegate porphyria. It's due to a chromosomal dominant inherited gene defect in heme production that is common, that has symptoms like AIP, but can also have blistering skin lesions when someone has sun exposure. Diagnosis is made by an elevated urinary PBG during an attack. Further testing is needed to identify elevated total urinary and plasma porphyrins to confirm the diagnosis of VP. Moving along, there is HCP, hereditary corporoporphyria, a chromosomal dominant inherited gene defect in heme production with symptoms similar to variegate porphyria, including the abdominal pain and the blistering skin lesions. Diagnosis is made by an elevated PBG during an acute attack. Further testing is needed to identify elevated total urinary plasma and stool porphyrins to determine the diagnosis of HCP. ALAD deficiency porphyria is a rare chromosomal recessive inherited gene defect in heme production with only a few cases reported worldwide. The symptoms are similar to acute intermittent porphyria. Diagnosis is made during acute attack by an elevated urinary corporoporphyrin and 5-aminolevulinic acid ALA rather than PBG. Porphyria cutanea tarda, PCT, is the most common type of the porphyrias. For some, the disease can be acquired over time, but for others it can be a chromosomal dominant inherited gene defect in heme production. Environmental factors include alcohol, hepatitis C, smoking, elevated iron, HIV, and estrogens can trigger the disease. The symptoms include blistering on sun-exposed areas of the skin, usually the head, hands, and face. In addition, the skin can tear easily with mild trauma. Patients are at risk of developing cirrhosis and even liver cancer. Diagnosis is made by elevated plasma and urinary porphyrins. EPP, erythropoietic protoporphyria, is a chromosomal recessive inherited gene defect in heme production with symptoms that usually occur in early childhood. Symptoms can include pain, burning, itching, swelling, and redness that develops soon after sunlight exposure. Generally, there is no blistering. Other symptoms include iron deficiency and complications from liver disease. Diagnosis is made by elevated plasma porphyrins and red blood cell protoporphyrins. Next, there is XLP, X-linked protoporphyria, a chromosomal X-linked dominant inherited gene defect in heme production. Symptoms are similar to patients with EPP. Diagnosis is made by elevated plasma porphyrins and red blood cell porphyrins. Genetic testing is needed to confirm the diagnosis of XLP versus EPP. And lastly, there's congenital erythropoietic porphyria. It's a chromosomal inherited gene defect in heme production with symptoms that can occur shortly after birth. Symptoms can be severe and include skin photosensitivity with blistering, scarring, and infections. Diagnosis is made by elevated total plasma and urinary porphyrins. So that's a description in lay terms of the different types of porphyria.
Dr. Heflin, patients often talk about their liver enzymes, or some even say their liver hurts. Could you tell us how porphyria affects the liver? And do they need special tests?
Well, yes, they do, and this is a question that I am commonly asked. The liver is affected by each type of porphyria, so liver function tests should be checked routinely. It's also important to note that the incidence of hepatocellular carcinoma is elevated in certain types of porphyria, primarily the acute porphyrias. So yes, you should have your liver functions checked routinely, and you should also have an ultrasound of your liver done yearly to detect hepatocellular carcinoma.
We often have patients saying that their doctor diagnosed them with acute porphyria or different porphyria, but when they go to an expert, the expert says, you don't have porphyria. How can this happen, and should I be retested?
You have to deal with this on an individual basis. Sometimes the primary care physician misinterprets the results and tells the patient that they're positive for a certain type of porphyria. Then they're referred to the expert who tells them that they did not have porphyria. This is why having the doctor packet that is provided by the American Porphyria Foundation will help eliminate this common problem of misdiagnosis.
Dr. Heflin, this may sound like an unusual question for an inherited disease, but we get this question often. Is porphyria contagious?
None of the porphyrias are contagious. However, acquired porphyria cutanea tarda can be caused by hepatitis C and rarely HIV. But no, they are not contagious.
Dr. Heflin, 90% of the questions that we're asked at the American Porphyria Foundation is about pain. And this goes from all types of porphyria. What can be done about pain?
For the pain relief, prompt treatment of underlying causes such as cessation of alcohol, certain drugs, and unsafe drugs is paramount. It's important to maintain adequate nutrition and fluid balance during acute attacks. Have an intake of at least 300 grams of carbohydrate. All of the porphyrias can be extremely painful. Commonly, the physicians don't grasp the intensity of the pain until later on in the disease, which is unfortunate for some patients. So pain management is problematic at times, and we suggest that the primary care physician refers to pain specialists. If you have a severe attack of an acute porphyria, IV heme is available. For patients with photosensitive porphyrias such as EPP, XLP, PCT, and CEP, ice packs, non-steroidals, and avoidance of the sun is important. Furthermore, a new treatment for EPP is available. It's called SENESSE, SENESSE. It's a subcutaneous, meaning under the skin, implant that allows for EPP patients to be in the sun. That's a great addition to the armamentarium of treatment for porphyria patients that allows for a lifestyle change for patients with phototoxicity.
Dr. Heflin, we have read often that there are certain drugs for acute porphyrias that are safe and some that are unsafe.
This is an extremely important topic. I believe that consulting the drug list on the American Porphyria Foundation website is extremely important because some drugs can precipitate life-threatening crisis, especially in the acute porphyrias.
You said that some drugs can be life-threatening. Has anyone ever died from taking the wrong drug?
Yes, unfortunately they have, and all the more reason to consult the Porphyria Foundation website of unsafe drugs. But those especially include barbiturates, dilantin, sulfa, and others.
Dr. Heflin, you mentioned that unsafe drugs can cause an acute attack. What else can cause acute porphyria to precipitate an attack?
There are many other things that can cause an acute porphyria attack. It can be brought on by certain drugs, hormones in women, environmental factors, including chemicals of various types, nutrition, including fasting and low carbohydrate diets, alcoholic beverages, medical and physical stress, and physical fatigue. Many times the trigger of an acute attack is unknown.
Patients have asked, can I have a seizure with an attack, or can my blood pressure go high?
Due to the porphyrins' effect on the brain, you can have seizures. You can also have decreased sodium, a condition called SIADH, along with blood pressure issues. Attacks can increase the heart rate, but generally the heart rate returns to normal when the attack is over. Patients can also develop hypertension, which needs to be closely managed. If attacks are hormonal or related to the menstrual cycle, then you have options. The premenstrual attacks are likely due to increased progesterone. If they're frequent, some doctors treat with a gonadotrophin releasing hormone analog like Lupron. Removal of the ovaries is generally not recommended unless there are other indications.
Since we're talking about acute porphyrias, can patients have problems with seizures or blood pressure?
They absolutely can, and sometimes these seizures are intractable and hard to manage. The porphyrin's direct toxicity to the brain can induce the seizures. Also, you can develop a condition called SIADH, which causes you to have an extremely low sodium, and this can cause seizures. Some patients will get elevated blood pressure, accelerated hypertension from the porphyria attack. They can also have an elevated heart rate, but generally the heart rate returns to normal when the attack is over. The hypertension can become chronic, in which case it needs to be very closely managed and treated.
Dr. Heflin, young women have often told us that they are having attacks related to their menses. Is this possible? And if so, what are the options to deal with it?
Yes, it's quite possible, and it's due to the increased progesterone that you have during your menstrual cycle. There are some treatments that are gonadotrophic releasing hormones, analogs of a medication called Lupron. Removal of the ovaries is generally not considered unless there are other comorbidities like ovarian cancer.
Can other health issues cause an acute attack?
Absolutely. Stress can precipitate an attack. Menstrual cycle can precipitate attacks. If you have other medical diagnoses that are stressing you, that can precipitate an attack. Certain drugs, as we spoke, poor nutrition, poor fluid intake, inadequate carbohydrate consumption, all of these things can precipitate an attack.
Dr. Heflin, you mentioned that urinary PBG and ALA and porphyrins were used as screening tests for an acute attack. Could you sort of elaborate on why do you use PBG and why can't you just use porphyrins?
Well, this is a diagnostic dilemma to us as diagnosticians and clinicians. Many other things can elevate urinary porphyrins. So you can't go by that to diagnose porphyria attack. PBG is always elevated during an acute porphyria attack. Also, one classic sign of an acute porphyria attack is you can have dark, tea-colored urine. PBG and ALA are also neurotoxins, so it's advisable to check your PBG and urine porphyrin levels at least once a year for routine testing. Whereas urinary porphyrins can be elevated by myriad reasons, nothing causes an elevated PBG other than an acute attack. This is what is so diagnostically important. Now let's talk briefly about the cutaneous porphyrias, CEP, EPP, XLP, and PCT. What do you commonly get asked by patients with the cutaneous porphyrias?
Well, most of them want to know, is the sunlight always harmful? Interestingly, when they're young, but particularly with EPP, the connection between sunlight hasn't been made. But is it always harmful?
Yes, sun sensitivity is the main symptom of these cutaneous porphyrias. VP and HCP, which are the acute porphyrias, can also have blistering sun sensitivity. The degree of sensitivity to sunlight varies considerably. Patients with high sensitivity normally have high levels of porphyrins in the blood plasma, which, depending on the type of porphyria, having originated from the liver or the bone marrow. Ultraviolet light interacts with porphyrins in such a way as to damage the skin tissue. Therefore, you should always protect yourself from sun exposure. I've been asked if patients need to use special sunscreens. Most patients with a cutaneous type of porphyria must learn to avoid the sunlight as much as possible. Physical sunscreens such as zinc oxide may be helpful. Protective clothing is also recommended.
Patients are often confused about what light should be avoided. They know sunlight, but are we talking UV light, visible light, artificial light?
Well,
what should they avoid?
This can be explained. Patients with EPP and XLP experience photosensitivity that starts in infancy or early childhood and is characterized by pain, redness, and itching of sun-exposed skin. The time after sun exposure to onset of symptoms is variable among patients. Variegate porphyria and rarely hereditary corpoporphyria, both are acute hepatic porphyrias, can also experience photosensitivity that manifests differently than in EPP and XLP patients. Also, porphyria cutanea tarda, a hepatic cutaneous porphyria, can cause skin friability, blistering skin lesions on sun-exposed areas. The photosensitivity in porphyria is to the light in the blue-violet spectrum of the visible light wavelength. The peak wavelength for light-mediated porphyrin excitation is 410 nanometers. Indoor light sources, including lights for surgical or dental procedures that emit within this spectrum, can be problematic. Yellow filters, which block out wavelengths below 470 nanometers, can be used to protect patients if needed. Fluorescent bulbs have little light within this spectrum, and typical LED lights for lighting purposes that also lack wavelengths of light within this spectrum. So we have recommendations as far as clothing to use. Avoidance of sun exposure, including through windows, is the most effective way of preventing photosensitivity reactions. Opaque, tightly knitted clothing which blocks exposure to visible light. Solumbra and other brands provide some protection, as do goggles, hats, and gloves. Now let's get into the treatment for EPP, because they do have treatment available. Let's further elaborate on the treatment for EPP. As I mentioned earlier in the presentation, there's a new medication called Scenesse. It's been approved by the FDA. It's a subcutaneous administered medication that is photoprotective. It's administered as a sustained release subcutaneous implant. Its administration results in skin darkening within a few days after placement of the implant. Monitoring for hepatic complications are recommended. Treatment of severe hepatic complications requires specialty care at a center with expertise in EPP and XLP. Why are some sun exposure responses different than others when the time in the sun and weather seem similar? A patient's sensitivity to light is dependent on the light quality, the duration of the exposure, and patient-specific variables, including geographic latitude and altitude, natural skin pigmentation, and other factors which are not fully understood.
Dr. Heflin, we know this doesn't happen often, but we are asked about bone marrow transplant. Is it a cure and is it recommended?
Yes.
In EPP and CEP.
Yes, it can be a cure and it can be life-saving, but it's associated with significant risk of complications, and it's only reserved for a very small subset of patients. Bone marrow transplantation is associated with significant risk, including anemia, lab studies suggestive of iron deficiency observed in some patients. It remains unknown whether iron therapy improves anemia in this setting or may worsen the photosensitivity. In conclusion, due to the rarity of these diseases, primary care physicians often have a difficult time making the diagnoses, so they'll refer commonly to subspecialists. For the acute porphyrias and EPP, CEP, and XLP, you should see a hematologist who is a blood specialist or a hepatologist who is a gastroenterologist with special liver training. And in PCT, these patients are commonly referred to a dermatologist for care. The number one thing is finding a physician who's willing to receive the additional training in porphyria diagnoses and getting connected to the right organization. You can always look at our website, porphyriafoundation.org, or call us at 866-APF-3635. It's been a pleasure talking with you. This is Dr. Joseph Heflin.